Welcome back to Mapping Healthcare on KDRT 95.7 FM in Davis, California, where a medic with a map explores healthcare around the world, highlights people who improve it, and shares what we can learn from them. This is your host, Dr. Sheikh. Today we're on a quiet, sun-drenched road hundreds of miles from the nearest city. A sudden accident turns a peaceful afternoon into a desperate race against time. For a patient with severe but survivable injuries in a place like this, the nearest clinic, no matter how dedicated they are, just doesn't have the specialized equipment or the intensive care beds to handle the situation. This is where retrieval medicine comes in. Retrieval medicine isn't just about transportation. It's about bringing the specialist expertise of a major hospital directly to the patient's side, stabilizing them, and then safely moving them. As those blades of an airplane propeller cut through the silence, it isn't just a transport vehicle arriving. It's basically a mobile intensive care unit, designed to bridge the gap between a remote area and life-saving care. For thousands of people in rural and remote areas, retrieval medicine is their only lifeline. The idea of medicine in the air goes back further than you'd think. The first recorded use of flight to move injured patients was back in 1870 during the Siege of Paris, when starving citizens used balloons to transport wounded soldiers out of the city. Fast forward to World War I, where aeromedical evacuation was used to quickly move soldiers from the battlefield. But it was really the Korean and Vietnam Wars that saw the proliferation of helicopters in healthcare. In those conflicts, getting a soldier to a hospital by air within that golden hour provided a significant boost in their survival rates. By the 1970s, civilian systems in the United States and Europe started adopting these military lessons. Today, countries with massive landmasses like Australia, Canada, and the United States have highly developed networks of both helicopters for short hops and fixed-wing airplanes for those long-distance retrievals. You may be thinking, isn't this just an ambulance with wings? Not exactly. A retrieval mission is a high-risk undertaking. You're working in an unfamiliar environment with restricted space, limited equipment, and very few hands to help. In the United States and Canada, we often see a nurse and a paramedic on an airplane like this. In Europe and Australia, a physician is typically part of the team. For severe but survivable trauma, highly specialized paramedics or doctors can make a real difference in survival. They're trained to perform complex procedures like rapid sequence induction or advanced airway management right there in the field or in the back of a moving aircraft. Let's talk a little physics. When you fly, your body's tissues don't receive enough oxygen due to a drop in atmospheric pressure. It's called hypobaric hypoxia. For a healthy person, it's no big deal. But for a critically ill patient with lung disease or severe trauma, it can be life-threatening. And then there's Boyle's law. As you go up, air expands. If a patient has a trapped pocket of air in their lungs, called a pneumothorax, it can expand by 35% at a high altitude, potentially crushing their lungs or heart. Even the little air-filled balloons on breathing tubes have to be monitored or filled with water instead of with air to prevent them from bursting or leaking. Because the stakes are so high, retrieval medicine has lots of techniques used in aviation safety. They use crew resource management, which means every single person on the team, from the pilot to a new nurse, is encouraged to speak up if they see something wrong. They use rigorous checklists because missing a single piece of equipment like a spare battery or an oxygen key can be catastrophic when you're 10,000 feet in the air. Today we're joined by Dr. Shannon Nott, the Chief Medical Officer with the Royal Flying Doctor Service in Australia. He's an anesthesiologist by training and works in remote general practice and retrieval medicine. The views expressed on the show are mine and those of my guests. So Shannon, welcome to Mapping Healthcare. When people hear the string of words, Royal Flying Doctor Service, they may imagine dramatic rescues. So, from your perspective as the Chief Medical Officer of the Royal Flying Doctor Service in Australia, how would you describe the everyday reality of rural and remote medicine in Australia, which is just an extremely large country with a diverse geography and a diversity of people?
Thanks, Ulfert, and thanks for having us on. And I think that that word that you used around diversity is appropriate one for rural and remote medicine. We are a very large country here in Australia, and we have a lot of people that are on our coastal fringes, particularly on the East Coast. And so the vast majority of people live in the urbanised environment, but there is a huge amount of geography. The vast majority of our country, in terms of the actual land mass, is rural and remote. And some communities are extremely remote. We're talking hours and hours. Like some people just going to groceries to the closest town to get groceries may be flight only, or it may be 6, 7, 8 hours away to a regional or slightly larger town. And so for us in rural medicine, we are dealing with, I suppose, similarities to a lot of rural and remote regions of the world. A lot of our communities are some of the most disadvantaged and vulnerable communities. Even though we are a very lucky country when it comes to healthcare spending, and our healthcare system, there are significant equity gaps that exist for rural and remote regions. And we see the disparities that exist in terms of healthcare outcome because of it. So higher rates of heart disease, lower life expectancy, higher cancer rates, patients presenting very late with pathology that you would expect in developing countries, we see in our rural and remote areas. And more broadly, if you think about geography, there's very different issues for desert communities as some of our tropical communities. And even between towns that may only be an hour or two apart, they have very different risk profiles. And so for an organisation like ours with the Royal Flying Doctors Service, we've been trying for nearly 100 years now to tailor services to not only meet the emergency needs, which a lot of people are aware of, so us flying into emergencies and crises, but how do we provide community-based care and care closer to home so we can address some of those underlying primary care and health equity gaps?
I live and work in California, and we have rural and remote communities here as well. But, you mentioned taking a flight to go get groceries. That's something I can't imagine for sure. So, definitely greater challenges there. And so, you work in remote general practice as well as in retrieval medicine. And retrieval medicine is a specialized branch of acute care that combines emergency medicine, anesthesia, intensive care, and it focuses on stabilizing and transporting people who are critically ill or injured. And your teams you work with, they provide ICU level care basically during transport via air or ground ambulance. And so I can just imagine how decision making must look really different in the air or on a remote landing strip, for example. So could you share an example of how clinicians that work in such a setting balance urgency, risk, uncertainty, all of those issues in those moments?
That's one of the biggest challenges for a lot of our staff, is balancing all of those elements. How much do we sort of stay and play, is what we say in terms of stabilizing a patient. But that obviously takes time versus trying to package someone up as quickly as possible and move them to definitive care. The reality is that we do have a lot of resources available to us in the plane. We are able to provide that ICU level care in our aircraft, out in some of the most remote regions of the world. But the reality is that some people need surgery, some people need quaternary hospitals, and there is nothing that we can do to provide that definitive care in the remote setting. We need to stabilize and move them. And so what we do here is that we obviously select doctors that are going to thrive in that environment. It is a very different environment to the hospital environment. Even if you think of a critical care patient in a small hospital, there will be 6, 7, 8 people that you can utilize to help you that have healthcare experience and various degrees of experience in different areas. For us, At best, you have a healthcare team of two, a doctor and a flight nurse, and then you utilize bystanders and your pilot to be able to help do more manual tasks if required. And so, even working in a setting where you have less hands, you have less resources, it is a tricky space, and not everybody is cut out for that. And so, for us, from selection through to the training we do, it is about us having the right people, but also providing them with the right skills and training to be able to make the best decisions that they can with the information that they've got and in the setting that they're working in. Because no 2 days are the same for our retrieval team. One day they might be on a clay plan out and off a property somewhere dealing with a motorbike accident. And the next they might be in a very, very small nurse run health facility where somebody's had a massive heart attack. And so decision making, clinical work is all based on context. And what we try and do is we simulate with our doctors as many scenarios as possible and then provide them with tools and processes to have shared mental models and also shared decision making. The way that technology has gone, we are able to, in most circumstances, allow our doctors on the ground to be able to phone a senior retrieval consultant so that we can ensure that not all of the decisions are left on an individual.
Yeah, and you brought up a really important point. You said you select for clinicians who thrive in such an environment. But let's just pause to talk about an issue that's a global workforce challenge. Just like in many places around the world, Australia as well faces persistent clinician shortages in rural and remote areas. And, these shortages, as we know, lead to poorer health outcomes, longer travel times for care. And around the world, including where I work, the problem is expected to worsen over the next few decades with national clinician shortfalls in most countries that especially affect these remote communities. So, what does it take, both personally and professionally, to attract, prepare, and retain clinicians who actually will thrive and continue to work in these types of practices?
Yeah, so Australia is not exempt from all of those challenges that you outlined, and it is one of the most challenging, I suppose, areas for any rural remote organisation to tackle. The way that we have been and continue to build upon our workforce is looking at a pipeline approach. How do we get high school students from our rural and remote areas interested in health careers? And then when they get into medical school or for nurses, nursing school, how do we as a health service provide student placements that provide them not only with a great education and training environment, but a positive space for them to say, going to rural and remote's not a scary thing. I can actually see that this can advance my career. I can have a great work-life balance. And then at every stage, if you think about to build a health professional or a doctor, we are building programs with either universities, with high schools, with medical colleges to have robust training programs in place and also hopefully rewarding jobs for individuals where they can see themselves not only come and learn, but it's a space where they can thrive professionally. It's a space where they can get their version of work-life balance. And for us also, it's about looking at, well, what are the things that drive an individual? Particularly in our retrieval space, we've been quite successful and we're starting to expand those type of processes and programs into our remote primary care spaces where we need more family physicians that can provide holistic care in the community.
With the Royal Flying Doctor Service, clinicians get in an airplane and they fly to the area they need to provide care. But let's talk a little bit about technology in this setting. So, beyond your clinical work, you yourself have conducted research on the role of telehealth in delivering care to remote communities. And technology is changing medicine everywhere. So, tell us a little bit about how telehealth, remote monitoring, or digital decision support transform the care that Royal Flying Doctor Service provides. And it's a two-part question. What's being done and where do you see the greatest untapped potential?
Yeah, so I think RFDS is, or the Royal Flying Doctor Service, is a great use case around how technology enablers have allowed us to address some really significant healthcare challenges. I mentioned before, we're coming up to our 100-year birthday very soon. And if you think about the concept of even when we were created as an organization, the utility of aviation or planes in the 1920s was fairly novel, particularly for a healthcare organisation. But the gentleman that founded RFDS, the Reverend John Flynn, had worked and lobbied significantly and managed to lease a plane off what's our now national airline, Qantas, to be able to start running emergency missions out into rural and remote areas to provide healthcare. And so that itself was an advancement. But if you look at that, as soon as they got the planes, they ran into the next problem, which was essentially, well, how do people let RFDS know they need help? And at that point, it was very much based upon communities or towns that were on the telegraph wires, where they used Morse code signals to be able to get back to bases to say we need help. At that point of time, very few really rural, remote communities in Australia were on the telegraph wires. And so people would have to jump on horseback and ride hours still to get to the nearest town. And so that created another problem. And so the early founders of RFDS worked with a German engineer at the time to create what was Australia's first pedal radio, where they essentially had a generator that someone pedaled, and then they were able to utilize, and the early version was Morse code signal and then subsequently voice, like a conventional UHF radio would be now. And they used that to be able to seek medical advice, but also call for help. And so I often talk about rural and remote telehealth and virtual care. And in my opinion, RFDS founded that, at least for our country, and has been using it for nearly 100 years to be able to provide advice into remote communities to get people to call. And there have been significant advancements around that too. So that same pedal radio was then utilized to create School of the Air. So communities without school education programs could actually still get some form of education through wireless. And so that even revolutionized, when you talk about social determinants, that started helping from just an education perspective. Today, if I fast forward that sort of nearly 100-year mark, we utilize telehealth and virtual care every day. Our doctors provide advice into rural and remote hospitals that have overbed cameras that we can control remotely. We use digital systems that are integrated with hospitals across our state. We obviously utilize video and telehealth into the home. For us, we've been also looking at remote patient monitoring programs for people with chronic disease as well. And we also provide 24/7 emergency advice lines out into remote areas that have no health infrastructure, where we utilize our medical chests. So essentially these chests that have emergency medications, and combined with telehealth, we're able to give people treatment for urgent issues or even stabilize emergency health challenges until we can get a plane or a road vehicle to them.
That's such a fascinating journey into the history of how technology started being used to provide rural and remote care. And, this area that you and your colleagues work in, retrieval medicine, it's basically what makes it possible for really sick or injured people in remote areas to get the care they need fast. It's all about getting the right team to the right patient, stabilizing them, safely moving them to a hospital that is equipped to treat them, and it makes a huge difference in outcomes. Let's talk a little bit about some of the lessons from all of this work that you and your colleagues do. Looking beyond Australia, what lessons from the Royal Flying Doctor Service model could inform rural or remote healthcare systems elsewhere in the world?
Yeah, so I think there's a couple of things. Most of the world, or people that have heard of the Royal Flying Doctor Service, know of our rural and remote sort of emergency and critical care services. And certainly there are countries around the world that have very poor infrastructure around rural and remote healthcare access, particularly in the event of an emergency. How do you get people to the right care as quickly as possible? And there are many, many countries, some quite advanced in their healthcare spending, that just haven't looked at that space and through a healthcare equity lens. And I think there are lessons to be learned through that everywhere. More broadly, and I think the bigger impact that we're less known for is the work that we do in community. Being able, through that truly universal healthcare lens, look at where are the most pressing healthcare needs for community and how do we bring care to them. Healthcare, at least in this country and for most places around the world, has set up a model where the customer comes to you. People come to the doctor and then they wait. The reality is that for those that are most vulnerable, those that are most disadvantaged, they don't have that luxury, whether it be that they can't afford things, whether it be that they've got no one in their community to say that they actually need further advanced help. That's the challenge. And for us at RFDS, we've been focusing a lot, particularly in my state here in New South Wales, a lot on primary care systems. We know through evidence that investment in family medicine, good quality primary care and preventative health care, that is the biggest return on investment that we can make globally. Yet it is one of the areas that is not necessarily funded well in most countries around the world. And so for us as a charity, as an organisation that looks after rural and remote communities, we have focused significantly on how do we provide high quality, comprehensive primary care and preventative health care in as close to home as possible for our most rural and remote communities. And we continue to do that. One of the things that we've got here in Australia at the moment is we're at a crossroads in terms of our primary care system. We are seeing less people interested in taking up general practice or family medicine, as it's known in the US. And we're seeing general practices as businesses closing down in our rural and remote areas because of lack of viability from a funding perspective. We in RFDS have started stepping into that space to be able to ensure that communities that are at risk of losing their primary care, that their general practice services, we can help step in.
Yeah, and that's such an important point you made. You know, the objective of your organization is not to go in, help people on a one-off basis, but it's to provide primary care, preventive care, and fill those gaps that are being created by a lack of these services and a lack of clinicians in this area. So really important shout out to primary and preventive care. And you're someone who's deeply committed to getting high quality care to people in really isolated communities. You bring both skill and a really grounded, patient focused approach to your job. So, on a more personal note, what moment or patient story has most shaped how you think about the purpose and the future of rural medicine and retrieval medicine?
There's so many patient stories, but I'll share one. I was working in a very remote, predominantly Aboriginal community. And this community had a very strong sense of culture and traditional law. And I remember working very hard in that community to try and build rapport and trust. This country, we've done a really poor job at looking after our First Nations people. And there has been, over the history of our country, a lot of trust broken, particularly in healthcare as well. And so I was in this community, and a lady who was an elder in this community had come up to me and wanted to talk to me about some health problems and health issues that she'd been having. And these health issues were related to what would be deemed as women's business in that community. And traditionally in that community, there's men's business, women's business, and it wouldn't cross. And so I listened and I thanked the lady to say, thank you for letting me know. I appreciate this is women's business. Do you want me to get you a female doctor or a female nurse? And she advised me no and started breaking down crying because she talked and shared about how she felt that she could trust the role that I was doing in the community and trust that I would look after people. And for me, it was a very poignant moment because that lady I ended up diagnosing with likely terminal cancer that day. And unfortunately, she passed away within 3 months of that appointment. which could have been picked up years and years in advance, because she knew that there was something going wrong, but she also felt that she couldn't trust anyone with something that was quite personal for her and was quite ingrained in sort of traditional women's business particularly. And so what that story reminds me is that medicine is a science, but the art of humanity that exists in medicine is probably one of the strongest things and the best things that we can practice as doctors. I get asked all the time by med students about all the critical care things and the gory things and those type of things, and that makes for a good news story or a talk. But the reality is it's the human element, the care, and taking time to listen to people that has allowed me to make the most impact. And I'm somebody that is really grateful that not only do I get to do critical care and sort of emergency work, but I do a lot of remote primary care. And it's in my remote primary care space that I know that I can make the most difference.
Thanks for sharing that story with us. And so, we spend the first half of our conversation talking about a high-level view of healthcare delivery and health policy. But, the story you shared really gives an on-the-ground look at trust and the human aspects of the work that you and your colleagues do. And, Shannon, we usually end each episode of Mapping Healthcare by talking a little bit about the place our guest works or lives in. So, we connect to the areas that surround you. And when you're not on an airplane taking care of people's health, you're based in Dubbo. It's a city in New South Wales in Australia. It's about 200 miles northwest of Sydney.
Dubbo is a regional town, and it's sort of the hub to the outback, I suppose, for New South Wales. You drive a little bit further out and you start hitting those red sands that many people have probably seen in pictures. I love it here. I live on just a small little farm where I've got my horses, and so I spend a lot of time in my spare time riding horses, riding motorbikes, camping. And so for those people that are interested in the outdoors, it is a great place to live and work. It's a thriving place where there are a lot of young families here as well, from all walks and talks of life. There are people who've come from all over the world here and all over Australia to make a living. And we've got some great cuisines, and for people from a multicultural background, we've got great Indian, Sri Lankan food, we've got great Vietnamese and Japanese foods. But then for anyone that's travelled through rural Australia, they know that the pub culture here is a big one. And so we've got some great pubs that give you some solid Australian pub food.
Before we close, Shannon, I really want to thank you for your time. And I also want to wish Royal Flying Doctor Service a happy 100th birthday.
Thank you.
So that was Dr. Shannon Nott telling us about retrieval medicine in rural and remote Australia. Clinicians like him work in a world where space is tight, hands are few, and every movement of the patient must be meticulously managed to protect their monitors and their lines. They aren't just fighting the clock, they're managing the invisible physics of flight. It's a field where communication techniques borrowed from pilots and a focus on safety monitoring keeps people safe. Today we've explored how these flying ICUs became the ultimate equalizer in healthcare, ensuring that your geography doesn't have to be your destiny. So as we wrap up this look at retrieval medicine, here are some things to take away. First, geography shouldn't dictate your survival. The core goal of retrieval medicine is equity of access. No matter how remote you are, you deserve the same standard of care as someone living next door to a major hospital. Second, this isn't just extra training. It's a distinct subspecialty, understanding the unique physiological stresses of flight and the logistics of mobile intensive care is what keeps patients alive in transit. And finally, systems improvement saves lives. The best equipment in the world doesn't matter without robust systems. Standardized operating procedures, constant checks and audits, and a culture of debriefing after every mission are what minimize risk and improve efficiency. Retrieval medicine is a testament to how far healthcare has come. From balloons in a besieged city to flying intensive care units that bridge the gap for the world's most remote communities. Thanks for tuning in. This was your host, Dr. Sheikh. You were listening to Mapping Healthcare on KDRT 95.7 FM. Connect with me on Instagram at Mapping Healthcare. If you enjoyed this episode, please leave a review. It helps get the show in front of new people.